16 million infants a year are born prematurely. That's about 11% of the global population. And there are a lot of stakeholders involved in caring for those infants and in deciding how those infants are cared for. So my question to you, Paula, is do you think that all of those stakeholders are really aware of how important human milk is to achieving optimal health for those infants in the short term and in the long term?
No, I would argue there's a lack of understanding on the part of certain people, because for the longest time we've just thought about human milk as a food, a way to nourish a baby and for a baby to grow. And the evidence now is that human milk, because of all the different bioactive components as well as the nutritional components, actually works to program health, both in terms of the short term and the long term. That's a relatively new concept, and I don't think that that has had the widespread acceptance in terms of all the stakeholders. I would argue that there's a huge movement globally among neonatologists and experts in this field clinically, but that disconnect is probably still there with administrators and third-party payers about the importance.
One of the first steps is to convince the administrators in the neonatal ward. You have made a wonderful start with your studies at Rush University Medical Center. Have those changed the perspectives of your hospital administrators?
Certainly the cost studies have changed the perspective of not only our administrators, but really our studies are heavily used throughout the United States and globally, I would add as well, because they're the first ones that actually have put a monetary value on human milk in the NICU. When we first designed those studies, which really goes back to almost 10 years ago now that we began, it was really with the focus that the main barriers to mothers providing a higher dose of milk over a longer exposure period for their babies, those main barriers were economically based. Not being able to access a breast pump, the hospital not having an adequate number of specialists to help the mothers, not having industry quality freezers to store the milk. All of those were cost barriers. So when we first designed the study, it was with the intent of saying that human milk for full-term babies may reduce the risk of infections, may help prevent some of the casual things you see in that first year of life, and perhaps thereafter as well. But those costs in a neonatal intensive care unit for what human milk can help prevent or lessen the risk of, those are huge costs. And those are necrotizing enterocolitis, late onset sepsis, and bronchopulmonary dysplasia or chronic lung disease. And then subsequently, the neurocognitive or neurodevelopmental outcome into childhood. So those are hugely expensive morbidities for which human milk is a very safe and very cost-effective intervention, or part of a bundle of interventions, I guess I would say, to do that. So yes, they have had that impact because we've shown that certain doses of human milk over certain exposure periods reduce not only the risks, but the cost of those morbidities in the neonatal intensive care unit.
So you mentioned the neurocognitive development. I think that's one that's really surprising to people who don't know a lot about the importance of human milk. How were you able to measure the impact of human milk on neurocognitive development, or the impact of not feeding 100% human milk?
Mm-hmm. So I guess we refer to the neurocognitive development as neurodevelopmental outcome, because it's an array of measures that, depending on the age of the child, you do through clinical follow-up. And when babies are born, very low birth weight or premature, especially the extremely premature babies, the babies are already at risk for neurodevelopmental problems, because when they're born, their brain is so small compared to what it would be at full term. So all of that area of the brain that needs to develop is basically under your care as a clinician in the hospital. Ordinarily, the baby would be in utero, but now you, with your nutrition and your, again, a bundle of things to work to protect and grow the brain. So this area has changed tremendously in the last several years, and that's where human milk comes in as a mechanism. Because the area of the brain that is growing most rapidly during this period of time in the premature is called the white matter. And it's the part that's all of the connectivity that is the, as we would think of it, the upper level thought, the quickness of reaction, everything that goes into what we would call a neurodevelopmental outcome. That area grows much more rapidly than the head overall, than the brain overall. And because it grows the most rapidly, it's also the most susceptible to environmental agents in the NICU. So for example, that would be the baby having problems maintaining oxygen levels. That might mean an infection. That might mean inflammation in the baby's body. All of those things are common exposures in the NICU. When a baby experiences any of those things, then those inflammation processes can actually affect that developing area of the brain. So what human milk is thought to do and why it's so important in the NICU, again, beyond what it is with a full-term baby, is because it not only helps to selectively grow that area of the brain. So with the high concentrations of special fats and certain growth factors that are really important with respect to the growth overall of the brain, there is what is called neuroprotection and neuromodulation by human milk. The neuroprotection means that the possibility that one of those insults is going to reach the brain is mediated by something in the milk. So that would be lactoferrin, insulin-like growth factor, that are present in mother's own milk with babies in the NICU. Those impact how those noxious environmental agents are going to affect the brain. So they're almost like a little a stopgap measure. They don't let that full impact affect the brain. So a baby could be going through active infection or active inflammation, and if the milk products themselves are in their own way not just growing the brain but protecting the brain. So that's what I would say. What is the underpinning for this? So as far as what we have done, our cohort of babies for which we showed a reduction in necrotizing enterocolitis, late onset sepsis, and bronchopulmonary dysplasia, we followed at 20 months corrected age with neurodevelopmental assessment scores. And what we were able to show with that is that there was truly a dose-response relationship between how much mother's own milk the babies got during the intensive care unit hospitalization and these scores at 20 months for babies in the NICU. So the babies that got the highest amount of milk had the highest neurodevelopmental scores, even after controlling for things that we know affect neurodevelopmental outcome, such as maternal education, growth of the baby, gender of the baby. And the other thing that, again, when we look at why and how it's so important in the NICU, is that each one of the morbidities I've mentioned, necrotizing enterocolitis, late onset sepsis, bronchopulmonary dysplasia, each of those morbidities is a separate risk factor for neurodevelopmental problems in this population. So that by simply reducing the incidence of those problems, you already increase the probability that the baby will have a better neurodevelopmental outcome. So human milk works both directly as for substrate for growth and neuroprotection, and it works indirectly by reducing the incidence of these complications that independently lead to these different problems. We're currently modeling the costs associated with that. We have data for the first 2 years as well that show a reduction in healthcare utilization costs in this population as a consequence of mother's own milk feedings. And we'll be studying that further out. We have a research application under review right now to follow these same babies out into age 9, where we'll be able to look at outcome scores in school and emotional development and the whole array of testing that you would do for children at this age.
mind-blowing, I would say, the impact on neurodevelopment, directly and indirectly, of human milk for these babies. So are you able to talk about then the potential economic costs for babies that don't get this human milk as preterm infants?
I can talk about it to a certain extent because, as I said, we will be looking at this cohort at an older age, and by then we will know who has required special education services as a consequence of the neurodevelopmental outcome. But when we look at studies in this population, regardless of human milk, so we look at babies that have lower scores in neurodevelopmental outcome, what we do know is that by childhood, the educational costs for the babies eclipse the healthcare costs. And for example, it was a kindergarten alone, a special needs child, even at kindergarten, is going to cost approximately $4,000 extra just for kindergarten alone as a consequence of having been born very low birth weight and requiring extra, like an individual educational plan. So we know even from the earliest ages that the education is likely to eclipse the healthcare costs. But even at that, the healthcare costs are not insignificant for this population either, because they will go on to have, for example, the BPD and chronic lung disease. A large part of these babies end up having some sort of asthmatic or needing extra care because of the fact that they've had lung and breathing issues. So that's a huge concern with this group of babies as well. So that by reducing that risk of chronic lung disease, you reduce that cost. The same thing by reducing, especially surgical necrotizing enterocolitis, which comes with not only high fatality, but the short bowel syndrome and all kinds of digestive issues. By reducing that, it's a significant healthcare savings. So not just the neurodevelopmental ones and not just in the NICU, but those big NICU morbidities kind of pave the way for other costs down the road to the families, to society, to education. So it's a lot of savings that could be attributable to increasing the use of mother's, I'm going to use mother's own milk because it's really different from donor milk, mother's own milk for this population of babies.
How long does this neurodevelopmental impairment or the benefits of human milk, how long does that impact a person's life then?
Well, the impact of neurodevelopmental problems in the preterm population is reasonably well studied. And especially for those babies that are, one standard deviation below the norm. When you get into that population, you're really looking at special education. You're probably looking at, and when you go further than that as well, you're really looking at lifelong support. You're looking at a lifelong disability that's going to impact income. It's going to impact the ability to live independently. So, and certainly the cost to society. So the potential really with human milk is to, as a part of a bundle in the NICU of best practices, is a way of minimizing the risk of lifelong complications and disability in this population.
One of the most impressive parts of your study is this exhaustive list you have of the costs of initiating and maintaining lactation. And you've said that those are the barriers for producing human milk or for breastfeeding in the NICU often. So could you talk about those costs?
Yes, that was actually when we began our initial study in 2007. It was really to target those barriers that are economic barriers, that if a mother wanted to provide milk for her baby, it really was her expense at doing so. Finding the pump, finding the kit, all of it was the mother's expense. And I even have begun to take issue with what we use. We say we provide mother's milk, but we acquire donor milk. So we acquire mother's donor milk because we say we need it. But if a mother is successful at providing her own milk or not, that's a provision. So I think even the nomenclature we use makes it sound like mother's own milk is optional. And if the mother can provide it, okay, and if she can't, okay. So when I look at economic barriers, we've done two different studies. One was the cost of providing 100 milliliters of milk, and the other was the institutional cost of acquiring milk. And what we showed with those studies is that basically if a mother simply has access to the breast pump, the kit, and the collection containers, nothing else, that it's less expensive to feed mother's own milk than either formula, and certainly than donor human milk. The other thing that we've looked at most recently is costing out over the course of the average 71-day stay in the NICU from our cohort of the 430 babies. We've costed out what would be the low and the high extremes for comprehensive lactation care in the neonatal intensive care unit. And when I say comprehensive, for us, that means that we employ 24 hours total, 24 hours of professional neonatal intensive care unit specialists in lactation. So that's our breastfeeding peer counselor team. So we pay for 24 hours total of those people. The mothers have access to them anytime that they need them. They have access then to the breast pump rental for a total of 3 months. The collection kit, we use a milk warmer. We use hematocrit measures. We use baby weight scale measures. So it's an extremely comprehensive program of lactation care. And our low estimate for that is $984 per baby per hospital stay. The high estimate is $1,200, and those variations are simply a fluctuation in the market price of renting the breast pump or the market price of buying the kit. So it's an extraordinarily cost-effective intervention. But what has been unsettling, I think, for many of us is that the only thing that we've been able to use our economic data for in the institution many times is that it's less expensive than donor milk, because now the slippery slope seems to be, well, if we don't have the mother's own milk, we just feed the donor milk. And the donor human milk is significantly less effective at reducing any of these complications, has not been shown to have any impact on neurodevelopmental outcome whatsoever, but it's often used as a substitute for mother's own milk because it's just easier to acquire. It's easier to order it. You just call or go online and they ship your milk to you, as opposed to finding the breast pumps and investing in the mother. So that's why so much of my interest lately has focused on the importance of mother's own milk as opposed to simply using donor milk as a replacement, because the impact of the two is markedly different, but they're very different processes by which you acquire them. It's more work, but it's less expensive to use the mother's own milk. And I think that's the bottom line. It's a cost-effective intervention that you're not going to duplicate or replicate with formula or donor milk.
You said that the maximum cost, according to your list of costs, would be $1,200 per NICU stay. So that's 71 days, is that right?
Right.
On average, for each infant. That sounds like peanuts. What is the daily cost of the hospital stay for those infants?
Oh, the daily cost would be in the thousands of dollars, depending upon where you are. And that's why I say this is a very inexpensive intervention for someone to say the mother has to find her own breast pump, or we're not going to invest in someone to help her, or we're not going to invest in industrial freezers that keep the milk safe. And that's why we did that, because the average baby born under 1,500 grams in our research was in the hospital 71 days. And that's very normal, for especially with the lower end of that weight range, which is often above 90 days. So that is the entire NICU hospital stay. The low was under $1,000, and the high was just over $1,200 for the 71-day total.
Is there a way to quantify economically the effort that's required? Because you said that it's a matter of effort versus cost. This is clearly cost effective, but maybe people don't want to invest the extra effort.
Well, the extra effort, for the most part, is translated into cost by having an expert who knows how to help mothers of babies in the NICU. They have to be experts in breast pump use, troubleshooting milk volume problems, using technology. And we have prepared a group of people we call breastfeeding peer counselors. They are former mothers of babies that have been cared for in our NICU, and many have gone on to become IBCLC. And we staff our unit with 3 of those people a day. So that basically is a 24-hour period of time, not necessarily around the clock, but 24 hours of direct care that's shared by all of the mothers. And obviously the time the mothers need the most help, it's front-loaded. They need a lot of help right in the beginning, and they need a lot of help when their babies are going to be feeding at the breast. But it's a very cost-effective way to optimize health outcomes for babies because the cost is so very low.
Based on your studies, based on the incredible impact of feeding human milk to preterm infants, what would you say to policymakers? What's your advice?
Well, we've spent a lot of time on doing certain ones of our papers so that they have a policy focus about the investment, because there's a whole body of science right now, especially when we look at the developmental origins, that shows that economically you have the biggest impact on investment when you invest in something that is going to impact life or health over the lifespan. And human milk is one of those. So we focus on the fact that it's a short-term cost that's very inexpensive, that has lifelong paybacks to society in terms of reduction in costs and improvement in health. And I think that the issue with policymakers is the truly not understanding why a mother in the NICU is different from a mother of a full-term baby. And a mother in the NICU must have a breast pump, and she must have a pump that is effective, efficient, comfortable, and convenient. You can't do it with hand expression. You can't do it with a cheaper model of pump. No matter how hard you try, the mothers won't make enough milk. So I think that the piece is that that type of equipment that mothers need and the infrastructure that a hospital needs have to be written into policy. And increasingly, I become interested in, instead of the mothers providing milk, I become interested in the whole idea of the hospital acquiring the milk. In other words, we say to the mothers, we must have your milk for your baby, the same as if we would for donor milk, and therefore we're going to provide you with the pump. We're going to provide you with what you need, not send you out searching for it somewhere while you're coping with the baby in the NICU who's sick. We're going to provide everything you need right here. So I think our model, at least, and this is so country specific, I know, but at least in the States, that's the area of work I'm interested in right now, is bringing this into the NICU. That's the NICU's responsibility to acquire the milk, as opposed to the mother's responsibility to provide it. Same as we use for donor milk.
That is extremely compelling.
Good.
Professor Paula Meier, thank you very much.
Thank you.